Uh, Good evening, everyone. I hope each and every one of you is doing well. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to tonight's session. Before we begin, I would like to invite Najib to lead us in an opening prayer.
أعوذ بالله من الشيطان الرجيم إن في خلق السماوات والأرض واختلاف الليل والنهار لآيات لأولي الألباب الذين يذكرون الله قياما وقعودا وعلى جنوبهم ويتفكرون في خلق السماوات والأرض ربنا ما خلقت هذا باطلا سبحانك فقنا عذاب النار ربنا إنك من تدخل النار فقد أخزيته وما للظالمين من أنصار ربنا إننا سمعنا مناديا ينادي للإيمان أن آمنوا بربكم فآمنا ربنا فاغفر لنا ذنوبنا وكفر عنا سيئاتنا وتوفنا مع الأبرار ربنا وآتنا ما وعدتنا على رسلك ولا تخزنا يوم القيامة إنك لا تخلف الميعاد صدق الله العظيم.
Thank you, Najib. Once again, good evening and a warm welcome to all of you. This session is proudly organized by Academics Department of MSAUN KNH. My name is Saadia and I serve as a research coordinator at MSAUN KNH, and I will be your moderator for tonight's session. So tonight, we are honored to host a presentation on how to read and interpret a head CT scan, which I think we can all agree is an important skill for every clinician. Our speaker is none other than Dr. Mohamed, a rising star in the field of neurosurgery. Dr. Mohamed is a fifth-year neurosurgery resident and deputy chief resident at KNH. He holds a BSc in medical physiology, MBCHB from UON, MSc in medical physiology, and is currently pursuing his Masters of Medicine in Neurosurgery. In addition to his clinical commitments, Dr. Mohamed is a tutorial fellow at the Department of Anatomy and Medical Physiology at University of Nairobi, and also serves as a tutorial assistant at the Department of Biomedical Sciences at Aga Khan University. And all I can say is that we are truly privileged to have him here to share his knowledge and expertise with us. Please join me in welcoming Dr. Mohamed. Doc, you're welcome.
Thank you very much for a warm welcome. Once again, I apologize to the audience. Unfortunately, my laptop just decided to update. So fortunately, I'd already shared the slides earlier. One of the things we are trying to implement in terms of teaching is what we call the flipped classroom. Flipped classroom means that the attendees or the people who the talk is being given to have an idea of what is going to be discussed. So they go through the material earlier, and then it's much easier with regards to that. So the reason it's called flipped classroom is because traditionally the classroom has been that you come, you teach, or you give a lecture, and then after that the students are given an assignment or they go and read afterwards. The reason why now we are moving to something called flipped classroom is that you go and read on the topic and the lecture is shared earlier. Then you come and quote unquote do the assignment in sort of the classroom setting. And the assignment is very case-based discussion. So you're just sort of like reviewing what you've gone through earlier. So tonight I just want to focus specifically on CT scan of the head I'm hoping that inshallah we'll have another session on maybe MRI at a different time. The reason why I wanted to focus on CT scan of the head is because, especially for the finalists, you will have as one of the stations on investigation, you can be given a CT of the head to be able to review. Now, I wanted just to be able to discuss it. So, are you able to put it on slideshow? Because it's not on slideshow from this side. Thank you. So I think we'll just go through that. So the task that we have tonight is to be able to interpret a head CT scan confidently, identify any abnormalities, and try to link it to case scenarios that exist. The target time that we have is about 5 to 7 minutes for this particular station, because the station will be 10 minutes long. So whenever you go into a station, remember the first minute or so, broadly speaking, is to be able to assist you to get through the, signing your name, etc. Then 1 minute or so for reading the question. Then 5 to 7 minutes for being able to go through the question and answer the relevant parts. And then after that, the last minute or so is just to tie up any loose ends and, to thank the lecturer. And then you're done with the station. So you always have to try to time yourself in that particular manner. Now, the goal is we're going to use a base to vertex approach. You can also use a vertex to base approach. There's nothing wrong with that, so long as you're able to go through it systematically. At the end of the day, that is what matters, and you're able to get what is needed. So next slide, please. Thank you. Now, why skull base to vertex or vertex to skull base? It gives an anatomical progression that makes sense and ensures that no region is missed. It also aligns with clinical practice. Remember, OSCEs tend to be very objective rather than being subjective. And the reasoning behind it is that when it is that objective, there's a standard way in which things are done. So the standard way in which things are done, if you're able to follow that, then that is what is in the lecturer's mind, and you're able to follow through that standard manner. And it's ideal for OSCE scoring, and it helps to correlate the findings that you see on the imaging with what the patient presented with in the history and in the clinical examination. So on the right of the screen, you can just be able to see a mid-sagittal image. And if you go systematically, you'll be able to see different levels, all the way from the foramen magnum, the cerebellum, the brainstem, there's the lower medulla, there's the upper medulla, there's the pons, there's the midbrain. Then after that, you come to the level of the third ventricle and the basal cisterns. Then what you have is you have the level of the lateral ventricle, the frontal horn, the body of the lateral ventricle. Then you move up towards the cortex, towards the cortex. So that is the systematic way that I would encourage us to go through it. Now, some people have been used to going through it systematically from up to down, and there's nothing wrong with that. The moral of the story that I want to be able to pass here is that we want to be able to go through off in a systematic manner. Next slide, please. Very good. Now, when we start at the base of the skull, what we have is that we start with the bones, the sinuses, and the brainstem. Then I think I've gone through that, progress towards the cerebellum, the ventricles, the cerebral hemispheres, and finally the vertex. The checklist that you want to be able to have is you want to be able to go through the bones, the soft tissues, the cisterns, the ventricles, and the parenchyma. So again, on the right side, what I have is a coronal scan that just shows us the progression coming down from the skull base all the way towards the vertex. So again, I keep on insisting, ladies and gentlemen, I want us to be able to go through in a systematic manner. Next slide, please. Okay, so we'll try to go in a stepwise manner. One is to verify the patient's image details. That's extremely important, And when verifying the patient's details, always check that the patient you have is the patient whose image you're looking at. Confirm the age, look at the date that the scan was done, what modality has been done. Again, a big problem I've seen with students is people generally tend to have a problem identifying what is an MRI versus a CT scan. So that is what I mean by modality. So at least before the exam, just make sure you go through enough images, regardless of wherever it is, at the level of the the brain, at the level of the abdomen, at the level of the chest, because you can be brought for any imaging of any kind. So what you have there is you will be able to see the modality. So please do not confuse any of them. Then you need to be also able to look at the window. So Sadia, I'm sorry, I think I've got my laptop to work because I want to point out details. Could I try and share my screen so that I see if it's working on my end? Thank you.
Yes, Doc, go ahead.
Yeah, so that at least I can point out what I'm referring to. Okay, Sadia, are you able to see my screen?
Yes, we can see it, but it's not in slideshow.
Okay, let me just put it on slideshow. Okay, confirm for me, please, if you are able to hear it.
Yes, perfect. It's on slideshow.
Thank you. Okay, so let me just minimize this. So I was just showing you that this is a coronal image that we have. And again, it's looking at the skull base. Let me just remove my phone from the meeting. Okay, good. So now I hope we go without any hitches. From the base of the skull all the way towards the vertex, you have the bones, you have the sinuses, you have the brainstem. Then you're progressing toward the level of the cerebellum, the ventricles, the cerebral hemispheres, all the way to the vertex. So you have a checklist at each particular point. You're going through the bones, the soft tissues, the cisterns, the ventricles, and the parenchyma. That's what you're actually going through at each level. Now, step one, I think I went through this, a number of things. We've gone through the name of the patient. You want to be able to have the correct age. You want to have the correct date. The modality is it a CT scan or an MRI? So in the CT scan, you'll see that this particular segment, the bone is quite prominent, regardless of the window. In the MRI, the skull will not be as prominent. So that's how you differentiate between the two. Then there's windows. So I'll also discuss this. Like this is a brain window. There's a bone window. So you need to be able to mention the window. Then also whether it is pre-contrast or post-contrast, or a non-contrast scan or a contrast scan. And you'll be able to see, if you look at the scan itself, you'll be able to see that either it's written here, post-contrast. If it's not written, you normally look at the blood vessels and you can see also the sinuses. So the sinuses would highlight and they would light up. And from this lighting up, what is going to happen is that how you know it's a contrast scan. Then confirm that it is in the right orientation. The left side is the left side and the right side is the right side. And then also you can give a small comment on the image quality, but this is not very common in CTs of the head, but you can be able to tell if an image is a poor quality. Sometimes you'll see scans that are done in a peripheral facility, so you're not able to make the best out of it. Or also the patient has not kept the scan well, So it has gone into water or something of the kind, and you'll see that the image quality is not the best. Now, in an exam setting, you will see that the image quality, they generally tend to bring a very good, clear quality, like what I'm showing you. Now, the tip I can give you with regard to the OSCEs is ensure that you verbalize this verbatim. In your small discussion groups, the more you practice, the better it will become. So an example here is Blogs Joe. This is maybe a 65-year-old male patient who has done a CT scan of the head, and this is an axial cut, which shows the brain window, and this is a pre-contrast scan. So we discussed the name, the age, the date, the cut, the modality, the window, and the contrast or not, and it has been oriented in the right manner. So the more you keep on verbalizing this, the more you're able to practice, the better you become. Now, this is just a sample that shows a brain versus a bone window. Now, in here, the brain window you'll be able to see. An example here is that it's showing some subarachnoid hemorrhage, which you can be able to see over here. Then there's something that we call a subdural window that is not very common. And then we have the bone window. So the commonest you will get is the brain window and the bone window. The bone window, you'll be able to see that the bone or the skull is prominent. In the brain window, you also have the skull being prominent, but you can be able to make out at least the ventricles and the brain matter. In the bone window, you cannot be able to make out that. So I've also seen the students who are rotating in neurosurgery, sometimes some of them would have some difficulties in differentiating between a brain window and a bone window. A bone window is more prominent. So it's like as if you have nulled the brain segment, and here you have not nulled the brain segment. So here the bone is more prominent. Bone windows tend to be very good to pick up, for example, fractures of the skull, which are maybe linear, non-displaced, that are not being able to be picked up very well on the brain window. Now, the other thing I want to talk about is you look at the skull base as you come. So remember, the skull base primarily is going to have the anterior cranial fossa, there's the middle cranial fossa, and there's the posterior cranial fossa. Now, using the bone window, you want to check for fractures, especially at the level of the temporal bone and the occipital bone. They would have patients, for example, that have got otorrhea, that would have a skull base fracture. So you want to be able to tell at the level of the skull base if there's a fracture there. Next, you want to assess the sinuses. So the sinuses you're assessing is the frontal sinus, there's the mastoid air sinus, there's the sphenoid air sinus, and you also have the maxillary sinus. And you want to see if there is fluid, because remember, a sinus is filled with air. So if you have a fluid air level, what do I mean by a fluid air level? If you look at the sinus, you can see a meniscus that is not normal. So that meniscus either can be blood, you can either have a mucosa or a mucocele that is forming. Normally, the sinuses should be dark on either side. So that's what is important. Now, the OSCE tip that I'll give you here that you're describing at this particular level, especially with skull-based fractures, you use the bone window settings on the CT. You use the bone window image. So this is just a small cartoon that is showing the different images in terms of the frontal bone, sphenoid bone, temporal bone, and occipital bone, and some of the common signs and symptoms that you would see. So if a patient of yours already comes with raccoon eyes or a halo sign, as an example, you know that most likely the skull base fracture is at the anterior skull base. If we have a middle skull base, most likely the temporal bone, they would have a hearing loss or a loss of balance. So most likely you have affected cranial nerve number 8. Then you would have something we call a battle sign. So a battle sign is a prominent discoloration that is going to be occurring at the mastoid level, and that's what you'd have. Then posterior, you'd have like a cervical spine injury that is associated, then a vertebral artery injury or a damage to the lower cranial nerves. Now, these are just some images that I shared with you to demonstrate skull-based fractures. Sometimes they're not very prominent, you might miss them, but if you have a keen eye, you would get them. So you can be able to see here, like at the sphenoid bone, you'd have a fracture. Here, you have a fracture. Again, ladies and gentlemen, remember that you want to be able to see that whatever you're calling a fracture is not a sinus, what am I calling? A suture. Remember where the sutures are. You have the coronal suture, you have the lambdoid suture. So commonly, sutures are on both sides. So if you see, for example, like here, look at this one here, and look at this one here. So most likely this is a suture between the occipital bone and the temporal bone. And what you can see over here is that you don't call this a fracture. But look at this image right above the eye on the bone window. There's this discontinuity in the bone or in the cortex of the bone, which is absent on the right side. So in this particular scenario, this is a fracture, but it is non-displaced. This one here is at the level of the clivus. So if you look closely, you can be able to see a hairline fracture that is over there. Same for here, you can be able to see the fracture here. Then apart from using the bone window with regards to fractures at the level or at the base of the skull, you use your 3D reconstruction and you can be able to see it prominently. So if you're not sure in the bone window, you have your 3D reconstruction. So this one is called a 3D reconstruction. You can see this patient was involved in a road traffic accident and even their teeth are all misplaced. They have multiple fractures here. And what you have here is there's also a fracture in the frontal bone. So what you confirm on the bone window, you can also be able to confirm on the 3D reconstruction. Now, next you also look at the soft tissues at the base of the skull. Now you remember I told you there's the anterior skull base, like this is the anterior skull base or the anterior cranial fossa that is starting off here. These are your eyeballs. This is the optic nerve, and here is the optic nerve. This one here is the middle cranial fossa. I hope you can be able to see my, I don't know if I can get my arrow. Hope you can see my arrow. This is the middle cranial fossa. This is the middle cranial fossa. The temporal bone delineates the middle cranial fossa posteriorly, and you can be able to see the wing of the sphenoid bone. Then here, what you have is the posterior cranial fossa. So if we look at this particular patient, there's obviously this hyperdense lesion that is on the left middle cranial fossa. So again, the terminology that you use is very important. For CT scan, we use the word density. For MRI, we use intensity. So do not confuse the two terms, especially when describing. Apart from that, you can see soft tissue swelling right here, anterior to the left eyeball. And then you can be able to see at the posterior cranial fossa, there are some punctate hyperdensities you can see. So this patient had quite a severe injury and it was more prominent on the left side. Check for any foreign bodies. I've seen patients who come with knives, but the knife tip is stuck somewhere here. We've had bullets that are stuck here, especially in the middle cranial fossa. A lot of people who view these scans, even at a level that is like a postgraduate level, even consultants level, sometimes people tend to miss out. So check for scalp swelling. You can be able to see the scalp, there's a bit of swelling there. Look at this one here and look at this side. So you can see the left side has been affected more. Check the mastoid air cells. These are your mastoid air cells that you can be able to see here on the right and look at the one on the left. Look at the opacification if they are similar amongst both. So the tip I want to give here is mention soft tissue findings for completeness. So go through the bone quickly, then go through the soft tissue quickly. Remember, we're doing all this in 5 minutes. So you should be able to quickly scan at each level as you go superiorly. Now, next, after we are done with the skull base, the other thing, sorry, I wanted to mention here, it's extremely key you want to discuss here. This one is called the foramen magnum. For the level of the foramen magnum, you will see, is there crowding? Is there no crowding? Crowding means that there is almost herniation that is occurring at that level. And the reason or your thinking behind it is there something upstream that is pushing something downwards? Remember the theory of Monroe and Kelly, or the doctrine of Monroe and Kelly, that the skull is a fixed volume and it has 3 components. 1 is brain matter, 2 is CSF, 3 is blood. At any one point, if any of the 3 components, their volume increases, then one other has to decrease, or then herniation is going to happen. So how do you know if there's crowding over here? Normally, when you look at a scan, I'll show you in the future scans, there's a good hypodense area that is around it. That is what we call a CSF cleft. If the CSF cleft is absent at the level of the foramen magnum, then you definitely have to consider that there's crowding over there. So at the level of the brainstem, so this is your brainstem, I put this scan, it's a mid-sagittal scan, but you'll also see it at the level of the axial, because the axials is what you'll be mostly using to describe. Go in order, look at the level of the foramen magnum. So foramen magnum, you see like here, there's that hypodensity. We can see my screen. Let me see if I can be able to zoom in. Magnify slide. Not giving me what I want. Okay. So you'll see at the level of the foramen magnum, then you have the medulla. So you have the lower medulla, then you have the upper medulla. Then when that particular part starts forming like a belly, almost like a pregnant woman, now you're at the level of the pons. So lower medulla would almost be just slightly above the level of the foramen magnum. You go to the upper medulla, then the pons. So when you start seeing a swelling like that, then you know that this is a patient, for example, that has a hyperdensity in the pons. Think of it like a pregnant woman who's standing. The head is the midbrain, the abdomen or the belly is going to be the pons, then the legs would come down to the spinal cord, and these are part of her thighs. So here you can be able to see the fourth ventricle. So you can see this is at the level of the pons, and at the fourth ventricle, there's a hyperdensity that is conical in shape, like a cone that traverses across the pons. Most likely, this is a pontine hemorrhage. Then you come to the level of the midbrain. So in summary, remember, we've started in order. At the skull base, you're looking at bones. Then you look at soft tissue quickly. Then you do the foramen magnum, then the lower medulla, the upper medulla, the pons. How do you differentiate between the medulla and the pons? I've told you to remember, like a pregnant woman. The pons are the pregnant part. So you can be able to see they're quite prominent. That's why I've put this one here. Then you describe what you see at the level of the pons. Then you come to the midbrain before you go above that. I hope that is clear. Then you also have to look at the cerebellum. That will give you completion of the posterior cranial fossa. In the cerebellum, you're checking for the effacement of the cerebellar folia. Then you check for any infarcts, any tumors, any hyperdensities, any atrophy of the cerebellum. All those are possibilities you can be able to see on the scan. Like here, you can be able to see we've lost the normal cerebellar folia that indicates some edema. Then on the left side, always please try to side where you see the lesion. On the left side, you can see a hyperdensity on the left cerebellar hemisphere. Remember, the cerebellum has got the central part, which is the vermis. Then you have the two cerebellar hemispheres, and you can be able to see that there's this hyperdensity in the left cerebellar hemisphere with loss of the folia of the cerebella, possibly indicating raised intracranial pressure because of effacement of the cerebella, folia, sulci, and gyri. Then comment on the symmetry. Always compare. You have been given two halves of the brain. So compare what you see on the right and what you see on the left. That is what is called symmetry. And comment on the cerebellar folia clarity. So that is the tip I can be able to give. So again, you can see this one is probably similar with this other one, but the difference comes in the side. So when you're approaching this one surgically, you would approach from the right side. When you're approaching this one surgically, you probably approach it from the left side. So it's very important for you to say where the lesion is. Now, next we describe the cistance. So this one is an MRI image that I put here just as a demonstration. So you can see in the MRI, these are your soft tissues. Do not confuse this with brain. This is a T2 because you can see CSF is dark or it's black. What I just wanted to point out here is the different cistance that we have. So you want to see, remember we have described our pons. The pregnant woman is here, her head is up here, these are her legs coming down. This is the cerebellum. Now here, what you see is in the cistance, mostly you're tending to look for any hyperdensities that are there, and most likely those are going to be subarachnoid hemorrhage. The correct way to describe it is the cistern effaced or not? Now, what I want to also point out to you, ladies and gentlemen, is the different cisterns that we have. See the color coding that we have. You'll be able to go through the slides. So please make sure you share with the audience members the slides. You can be able to see here, like this is the suprasellar cistern. This is, I think, some kind of brown. Then here we have the ambient cistern. You can be able to see there. Then here we have the superior cerebellar system that is over there. Then this blue here, this one should be the fourth ventricle that is right there. Then here, this light kind of blue, okay, this one is the prepontine. You can see this sort of lime green. So prepontine system, then premedullary system that you have over there. Then you have your superior cerebellar system. Then here, this blue we have here, this one should be the quadrigeminal system. So most commonly when you're looking at a scan, the effacement would occur somewhere over here. So you have your quadrigeminal is here. This one is going to be your prepontine, your premedullary, and then your supracerebellar system. So just make sure you go through the anatomy of the system so that you're able to know it. Then we have cisterna magna, which is right here. The large system separates the medulla from the cerebellum. So the correct terminology that you want to use, if you see, is that there's an effaced system, and you want to be saying which kind of system it is or which location of the system it is. Now, what does effacement of the system indicate? That there's raised intracranial pressure. So before I go to the ventricles, just a quick summary so that we are all together. We've started at the base of the skull. We've quickly described the bony architecture. We've described the soft tissues at the base of the skull. We have gone in an orderly manner from anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Then we came to the brainstem at all the different levels. At the level of the foramen magnum, the lower medulla, the upper medulla, the pons, then the midbrain. Then you quickly look at the cerebellum, the hemispheres of the cerebellum, and the vermis. Then next, you give a quick comment on the systems, because all these things, it seems they are very long because I'm discussing them in detail. But when you look at them, remember you're giving a statement on each of them. At the level of the lower medulla, there is no hypo or hypointense. The anatomy is maintained. Then you go to the cerebellum, or there is a hyperdensity at the level of the cerebellum in the right cerebellar hemisphere, and there's effacement of the folia. The basal systems, the suprasellar, prepontine, and the premedullary systems are also effaced. That could indicate there's raised intracranial pressure, or there's a hyperdensity at that level that probably indicates a subarachnoid hemorrhage. So it's one statement that you're giving at each level. I'm going through in detail because I want you guys to discuss and know what level anatomically we are discussing. Next, we come to the ventricles. So remember, the ventricles are four. You have the two lateral ventricles, okay? You can be able to see the frontal horns. You can see the occipital horns. Then this one right here should be the temporal horns. Then here where my arrow is, ladies and gentlemen, is the third ventricle. You can see normally the third ventricle is a slit-like appearance, but here it is sort of rounded. Then finally, we have the fourth ventricle. The fourth ventricle is almost described as a Maasai arrowhead. It is thin, narrow, and it forms like a slit or a crescent shaped. But here you can see that it is also quite dilated. So this patient has got dilatation at all the levels. So probably dilatation, this would be a this would be a communicating hydrocephalus, or what we call extraventricular hydrocephalus, that is outside the ventricular four ventricles. If, for example, the fourth ventricle was normal, but the third ventricle and the lateral ventricles are dilated, that one would be something like an aqueductal stenosis. So also just make sure that you know the outline of the different ventricles. So what are you assessing in the ventricles? You're checking if they're enlarged and the size. Then you assess for any intraventricular hemorrhage. So intraventricular hemorrhage, like you'd see some bright areas, like this one most likely the choroid plexus that you can be able to see over here, but I'll show you an image of intraventricular hemorrhage. Sometimes it can be compressed or it can be shifted. So quantify the ventricular size. So you say, are they dilated? Are they enlarged? And then discuss about a midline shift. Now, next you look at the midline structures. Midline structures, you want to see, is there a midline shift or not? You look at the falx cerebri, you have the septum pellucidum, and those are the two things that will help you the shift. So ideally, in this patient, you can be able to see the frontal bone, you can see the occipital bone, you can see the internal occipital protuberance going all the way to the frontal bone. This is the ideal midline. Then you can see the septum pellucidum has been shifted. Now, when you talk about a shift, you talk about a shift to what side? So you talk about a shift, in this case, a shift to the left. There's also a shift that possibly, for example, can happen to the right. So if a shift occurs to the left, then you know that here there's a problem on the left, on the right side. My apologies. So you can also measure the midline shift, but you don't have time to do that in an exam. So you just say there's a midline shift to the left as evidenced by the septum pellucidum and the falx cerebri being shifted. So this is your falx that's over here. And you can also use the lateral ventricle because the lateral ventricle is also midline, has been shifted to that side. And you will say that there is a shift to the left with a possibility of mass effect from the right. So there are certain terminologies that I want you guys to be able to learn over time so that you're able to see. Now, next, you see we have gone in order. We've talked about the midline structures. We've gone through the ventricles. So you'll talk at the level of the third ventricle, at the level of the lateral ventricles. Then now you come to the cerebral parenchyma. Remember cerebral parenchyma, you've started at the level of the temporal lobes. Then you have your frontal horns, sorry, not frontal horns, your frontal lobes, your parietal lobes. So this one, you can see is the central sulcus that separates over here. Then you have your occipital lobe. So at the level of the cerebral parenchyma, what are you looking at? You're looking for any hypodensities, hyperdensities. You're assessing for gray-white matter differentiation. So you can see here, there's good gray-white matter differentiation, but you can see here, there's loss of gray-white matter differentiation. So I put this scan as an example that you can see what you call effacement of gray-white matter differentiation versus normal. Then the tip I want to give you here, ladies and gentlemen, is describe the location. So is it left frontal? Like this one probably would become left parietal. So number one, on which hemisphere is it? Is it left or right? And then what lobe is the lesion? So this is an example. You can even have a bleed in the frontal lobe. So I'll show you some scans and we can go through them. Then quickly, you want to be able to describe any masses and lesions. You cite where they are. You discuss about the density. You can discuss the shape. Are they diffuse? Are they well circumscribed? Like this one, you can see it's well circumscribed and it has a good outline with hypodensities that are around it. So most likely this is edema. Then there's something that we call ankle herniation, where the ankles herniates from there. Like this side, you have a right ankle herniation. Then discuss, is there a midline shift? Is there herniation? Then is this in a contrast scan or not? So for example, in a contrast scan, you would see, you compare a pre-contrast and a post-contrast, and you'd see this becomes, as an example, you see what you call a ring enhancing lesion. And you see the enhancement pattern. Good. So now I think I've gone in great detail all the way from the base of the skull up to the vertex. So in summary, before I go to specific findings that you can find on a scan, where do you start? You start by talking about, I call it a preamble. The preamble that you're talking about is, what is the name of the patient, the age, when was the scan done, what is the gender of the patient, what kind of cut is it? Remember, you're going to have either axial cut, coronal cut, sagittal cut. Then you discuss the window. Is it a bone window? Is it a brain window? And what is the extent? Is it starting from the, so you can say it extends from the base of skull to the vertex. Those are the important things. So there are about 7 things I believe I've mentioned. So name 1, age 2, gender 3, when was it done 4, the cut 5, the modality, you have to say that this is a head CT scan, or if it's an MRI, that's 6. I've said the cut, then you talk about the window, that is 7. Then the extent, 8. So in that stage, for all of you who are attending the meeting, there are 8 things that you must always introduce. You get your marks on that. Start at the base of the skull. Any bony fractures, look at the soft tissue quickly. Then go in levels, start in the brainstem, lower foramen magnum, lower medulla, upper medulla, horns, midbrain. Then you quickly go to the cerebellum. Cerebellum, look at 2 areas. The hemispheres, look at the vermis. Discuss any asymmetry, loss of folia, any hyper or hypo densities that are there, and where is it located. Quickly come to the cistants. Are they effaced or they are normal?
Then quickly come up to the levels of the ventricle. At the level of the third ventricle, then you're also looking at the cellar supercellar area. Then you're coming to the lateral ventricles. Are they shifted? Is there any midline shift? Talk about midline structures. Then you come to the cerebral parenchyma all the way up to the vertex. So that is something that I want us to do and practice from base of skull up to the vertex. Now, quickly, I want to find out, you can also have another technique where you're going from inside to outside, or from outside to inside. Now, from outside to inside, we start at the level of subgaleal hematoma. Now, an example of this is a child who had a scan, CT scan that was done, and this patient underwent vacuum forceps assisted delivery, and you can also have sometimes head trauma. So you can see it's above the bone, but it is below the skin. So there's an increased isodensity that's over here, and most likely this is a subgaleal hematoma. Remember, the layers of the scalp, there are 5. There's the skin, connective tissue, aponeurosis, loose areolar tissue. So most likely the loose areolar tissue is the subgaleal space below the gallia aponeurotica. That's why it's called subgaleal space. Then you can see here it's extending from ear to ear. Here you can see the sagittal cut. So if you're coming from outside to inside, you can see a subgaleal hematoma as an example, and I've shown you how it looks like. Then next, we come to the level of the bone. At the level of the bone, we look at a scan. Remember, this one you can see it on the brain window. You can see that there's a depressed skull fracture. Then on the same scan, you can be able to see on the 3D scan or on the 3D reconstruction, this is a 34-year-old male who was involved in a road traffic accident as a passenger of a speeding motorcycle without a helmet. So now at the level of the bone, you can have 2 things. You can either have a depressed skull fracture or you can have a linear skull fracture. Next, after the bone, you come to below the bone. So below the bone and above the dura. Okay, remember, the meninges are 3. There is dura mater, arachnoid mater, and pia mater. So above the bone, sorry, below the bone, but above the dura, we call it an epidural hematoma as an example. So here you'd see it, it would have this appearance. It does not cross the suture lines. So it's convex or lens shaped. Most commonly, it is caused by an arterial bleed. Not all the time, mark my words, most commonly in 80% to 90%. Sometimes you can even have venous bleeds that occur there. And the patient commonly would present with a lucid interval. That is an epidural or an extradural hematoma. Then next you come to a subdural hematoma. Subdural is below the dura, but above the arachnoid. So you can see I'm going in a structured manner. I started below the skin, above the bone, then the bone itself, then up below the bone, above the dura. Then you have below the dura, above the arachnoid. So here we have what we call a subdural hematoma. It can take a concave or a crescent shape. The unique thing about here, this one, is that it's able to cross suture lines. And most commonly, again, the keyword I'm using here is most commonly, it is from bridging veins. It's commonly seen in elderly patients because of shrinkage of the brain, and in alcoholics. Why? Again, because the brain has shrunk. Therefore, the bridging veins commonly would tear. Or you can see it in very young children where the brain has not yet developed and there's brain atrophy. So you can have subdural hematoma. Now, subdural hematoma, I'll discuss it in this next slide. Sorry, this is a busy slide, but I wanted just to present the different ways in which it can present. So for example, here in this scan, this R is the right side. You can see this crescenteric shape. Sometimes it's easy to miss, especially if they're bilateral. But here you can see the different densities. So this is a hypodensity, this is an isodensity. So you'll see with subdural hematomas, the older the blood becomes, the more hypodense it becomes. So acute bleeds normally would become hyperdense, then subacute, which is from 3 to 7 days, they're going to become isodense. Then you have chronic bleeds, which are now dark, like in this case. So like this one, you'd call it a mixed density. So there's an acute bleed with a chronic bleed that has occurred. Then sometimes you'd see like some fibers or some fibrillations that are formed. That is what we call a chronic subdural hematoma with membranes. So that's what I wanted to put out to you guys. So now we are below the dura, but above the arachnoid. Now you can also go below the arachnoid, what you call a subarachnoid hemorrhage. So this is just one that is showing us the demonstration of all of them. So like here you have a subarachnoid, you can be able to see it's below the dura. Actually, sorry, below the arachnoid, but above the pia. So that's what you get called a subarachnoid bleed. Then you have inside the brain. So that is below the pia mater. And inside the brain, you have here, this is called a parenchymal bleed or intracortical bleed. Then inside completely, you're inside the further in relatively to the brain parenchyma, you can have a bleed in the ventricles. And this is what we call an intraparenchymal bleed. So this is just a table that I borrowed from one of the papers that just shows you the imaging at each level. What is the common mechanisms you can see? What are the common sources? What are the shapes and the presentation? But if you go through the anatomy, as I showed you, from vertex going to up and from outside coming in, you'll be able to tell the location. Make sure that you side it from each side. So we are almost approaching the time that I was allocated. So I also have to give some time for question and answers from the audience. In conclusion, you need to move in a systematic manner. Make sure that you go through it in a detailed manner so that you don't miss anything. Do not focus only on the pathology. Secondly, practice makes perfect. So practice makes perfect. You verbalize each step in your discussion, small discussion groups, so that it's almost like second nature. Like you see, when I'm reading through the scans, there are many things that have just, sort of glanced over and I'm able to do it so that even you'll be able to, like in postgraduate level, you're given a scan and you should be able to interpret it in a minute or less. So when I tell you guys are given 7 minutes, you're a bit lucky comparatively. So 7 minutes is a very, very long time, like at my level, to go through a scan. But like a minute, you've already glanced, you've gone through it, you've looked at the details, you've gone vertex to, skull base to vertex, from outside coming in. You've gone through each level and you're able to describe where the pathologies are. Then practice with CT images to ace your OSCEs, because this can be a station that you can get in one of the OSCEs in investigation station. Thank you very much. I think that's all I had for you. So I'd welcome any contributions, any comments from the group. Back to you, Sadia. I think you're the moderator for this session.
Thank you, Doc. I think there are some questions that require clarifications in the chat box.
Let me see what we have. Okay, so someone is asking, kindly point the soft tissue swelling. So let me go to that scan. So this is an example of soft tissue swelling that you can be able to see at the subgallio. But I believe this was a question asked when I was going through the skull base, brainstem. So here, like you can see, this is a soft tissue swelling. So you can see this eyeball. I hope I'm okay. This is another eyeball. You can see here, soft tissue, how it's normal. But look at here, there's this isodense lesion you can be able to see here. Then look at here in the subtemporal space. Compare this. I hope, Sadia, you can see my PowerPoint. My pointer.
Yes, Doc, we can see.
Yeah, so it's a matter of comparison between the two sides. So look at this side and then look at this side. And then here, there's also some bit of soft tissue swelling. Reason being, if you look at coup contre coup injuries, most likely this patient hit their head first. Then when they hit their head, they bumped back into something and hit something back here. So you can see there's also some soft tissue swelling. So I hope I've answered that question with regards to pointing to the soft tissue swelling. So someone recording, yes, okay, that's fine. Do they bring one CT scan images or a series? So most commonly, Billy, the one that I have come across is you have one scan Remember, you have 10 minutes, so the examiners have to be very fair to you. So you're given one scan and you're given that scan to describe it. At the level of postgraduates, you have a station, you can even be given 10 scans to go through in 10 minutes. Because that's like our expectation is a bit higher. But at your level, if it's a station for investigation and you have a scan, it can be an X-ray. And remember, it has to be standard. So they have to find one that everyone should be able to answer. So you're given one scan. If you go in a systematic manner, you're able to go through it very well. How would you differentiate between temporal and parietal lobes? So most commonly, the temporal lobes are already within the middle cranial fossa. If you look at the middle cranial fossa here, Omar, you can be able to see this is the temporal lobes. Let me see if I have a scan. Sorry, that is showing a mid-sagittal. Okay, so like here, this is the cerebellum. This is the occipital lobe. You can see the frontal lobe, that's the central sulcus there. This is the parieto-occipital notch that's over there. So remember, I'm looking at mid-sagittal, but if you see this same scan over here, I hope you can see my pointer. This is your sylvian fissure. So the sylvian fissure is going to separate your temporal lobe from your parietal lobe. So that's how you get the difference between the two. I hope I've answered you. If I've not answered, please just feel free to unmute yourself and ask. I don't mind. So I've answered that. Herse is asking, can you give us an example of how to combine all these steps, perhaps in a normal CT image? Okay, so I can attempt to do that. Now, the unfortunate bit is I don't have a scan that shows me all the levels, but I think I've done that as I'm going. So just as an example, I would go through a patient, like maybe who has got this spontaneous bleed, and the other segments are normal. So I would probably use this as an example. This is patient XYZ, who's 40 years old, has come in, XYZ, a 40-year-old patient, has got a CT scan that was done on blah, 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 shows an axial cut and a sagittal cut, which shows the brain window, starting from the base of the skull up to the vertex. So starting at the level of the foramen magnum, there is no crowding that has happened at the level of the foramen magnum. The lower medulla is midline, and there are no hyperdensities or hypodensities in that area. The upper medulla is also midline, no hyper or hypodensities. The pons on the axial cut show that there's a hyperdensity that is conical in shape, but it's not pushing the fourth ventricle. The fourth ventricle maintains its shape. The hypodensities around this conical hyperdensity, most likely, that's edema. The cerebellum has lost its folia, but there are no hyper or hypodensities within the cerebellum in the posterior fossa. At the level of the middle cranial fossa, there is no hyper or hypodensities that are present. Then I move up to the level of the third ventricle. I move up to the level of the lateral ventricle, which I cannot be able to tell here, but I expect that it's midline. There are no hyper or hypodensities within the lateral ventricles. Then at the level of the cerebral parenchyma, the frontal lobe shows that there is some hypodensities in the frontal region, in the midline area. The parietal lobe shows the sulci and gyri that have been in their normal formation and they're not effaced. The occipital lobe shows there is effacement of the gyri and sulci. That's an example in terms of how I want you guys to know. Then you just give a summary in terms of the positive findings at the end. So this is XYZ with a hyperdensity that is conical in shape in the pontine region. Most likely, it's a pontine hemorrhage. Good. So next time, I think I'll include a normal CT so that we go through the different levels. But for a summary purpose, that's how I do it. How would you differentiate a chronic bleed from an ischemic stroke? On the CT scan, it is generally hard to differentiate it, but most commonly ischemic strokes would be in the parenchyma itself relative to outside or above the higher or the arachnoid matter. That's one way. Chronic bleeds, the ones that we have, you would see it resolving, but the best way or the gold standard of differentiating between the two is an MRI. So on a CT, you might suspect either of them and still have them as a differential, but an MRI will be able to differentiate for you between the T1 and the T2 segments. How do you tell brain contusion on CT? Good question. So on CT, you'd see there's just an area with a small hyperdensity. The way I normally think of it is that a contusion is a small intraparenchymal hemorrhage. They can be multiple or it can be single. So that is what I would say is a brain contusion. So it's within the brain matter, most commonly near the poles. So you'd see it right here near the temporal pole or near the frontal poles or the occipital poles. And the reason behind that is this is where the brain, remember the brain is floating here, but when it's impacted suddenly, it hits the front and it hits the back. From that injury, from that bruise, that's what we call a brain contusion. Okay, so Samad says, can you give us some images in slides so we can practice? Yes, I can do that. So it's 8:10. Now, since we've gone through this, I don't know, maybe we can have another session next week so that we've gone through this, you guys go through this, I've shared the slides, then we can just have a session that we're going through practicing verbally the specific images, like what do you think this is, describe it, then we give you 5 minutes and you're going through that. So I think we can organize with the MSAUN team on that. Recap the pre and post contrast. So pre and post contrast, how do you differentiate between the two? The easiest way is if you look at the scan, sometimes here at the bottom, it's written contrast. So that when you know it's a post contrast scan. Or some they'll write for you pre-contrast, you know that's a pre-contrast scan. However, some people do not write for you, whether it's pre or post contrast. So what happens with that is you need to be able to see the vessels. So like, I think I had a scan that was contrasts. Like you see, this is a non-contrast scan. You cannot be able to tell any of the vessels. You cannot be able to see any of the sinuses. If the sinuses are lighting up, which is the superior sagittal sinus, inferior sagittal sinus, the temporal sinuses, etc., you'll be able to see that's a contrast scan. So, like you see, this is a contrast scan. If we look at the falx cerebri, this is where the straight sinus is. So you'll see it is lighting up. So when it is lighting up, you'll see that is a contrast scan. But commonly, they have labeled it. Like you see, this one is a contrast scan, and be able to tell the middle cerebral artery that's over there. Can be able to see the two vein of Galen joining here to give you the straight sinus. So that is actually, sorry, this is a non-contrast. But here, then I think this is spillage because this one here should be the subarachnoid space. So most likely there's a bleed here or there's a lesion that has bled, so you can be able to see that. Let me see one that is, yeah, like this should be a contrast scan. You can see, look at this. You can see the falx lighting up. Remember within the falx, what you have is you have the sinus. Look at this sinus here. So that's how you differentiate. How to differentiate MRI from CT. So look at this. You can see the outline of the skull. Skull, S-K-U-L-L. So the skull is well outlined compared to an MRI. Look at an MR. You can see in all of them how it is here. I think I had one MRI. Look at this. This is an MRI. You see the MRI over here. What you have is the bone. Look at the bone here. This is the bone, this dark area. You don't have that classical bone or skull that appears. This is soft tissue. Remember, your bone does not go down to the neck. So in an MRI, you don't have that classical surrounding hyperdense area that is over there. But In a CT scan, look at this, like look at the sagittal images that I'm posting. I'll show you, like look at this one. You see here, this is soft tissue, but you can see the skull base coming like that. You can even see the brightness or how white this one is and how white this one is. There's definitely a difference between the two. I hope I've answered that. Then within the intraparenchymal, kindly clarify the temporal and parietal lobes. So let's see, intraparenchymal bleed. So here, quite hard to tell the temporal lobes because we're at the level of the lateral ventricles. So the temporal lobes would be much lower, probably in the level of the cranial, middle cranial fossa. So here you have, most likely this could be part of the central sulcus, probably. So that's the frontal lobe. It should be the parietal lobe. Then most likely this is where the notch is, but hard again to tell because there's effacement. So if there's effacement, you cannot be able to clearly tell the sulci in the gyri, but approximately around here, this is where occipital lobe is going to be. So I hope I've answered. In axial view, yeah, this is in axial view. I hope you can see. Can you see my arrow, Sadia?
Yes, Doc, we can see.
Yeah, so this is an axial view. So here you can't tell the temporal lobe from here. So most likely the temporal lobe would be much lower here as an example. This is the middle cranial fossa. So this is the temporal lobe that's occupying here. This is at a higher level. So this cut, you can see the temporal lobe. In this cut, you can see the temporal lobe and the cerebellum and the fourth ventricle. You can see the mastoid sinuses. This is the temporal bone. You can see that separates the middle cranial fossa from the posterior cranial fossa. I hope I've answered you. Next we go to, please recap on the different ventricles. So different ventricles, let me see if I have this one. I can use this one. I can use this one. So here, these are axial cuts. So in axial cuts, you start from up here. These are your lateral ventricles that are starting to be visible. So lateral ventricles all the way. Then here, in the lateral ventricle, you starting to see, what is it called? The third ventricle. So you can see the third. This is the third. So here, remember the third normally is going to be slit shaped. Then as you go much lower from the third, you start seeing this should probably be part of the aqueduct. Then here you have the fourth ventricle. Remember the fourth ventricle is in the posterior cranial fossa. So fourth, third. So here you still have the cut here, shows part of the body of the lateral ventricle, but it's narrowing. This actually is part of the body. This is not the third, sorry. The third is from here. This is the cut which shows, because it's continuous. You can see the frontal horns. This probably should be part of the body. This is the occipital horns, frontal horns. And this is the body and atrium of the lateral ventricle, occipital horn, frontal horns, and then you're going all the way up to the lateral ventricle. So lateral, then you start seeing third, fourth, and then the horns of the lateral ventricle. Good. So I hope I've answered everything on my end. I don't know if there are any people who would want to unmute and maybe add a point or clarify or something. Then I'll hand over the meeting back to the organizing team. Okay, thank you very much. It was a wonderful session. I don't want to keep you too long. I'll hand over the meeting back to the organizers.
Okay. Thank you so much, Doc, for the insightful and practical session. We truly appreciate you sharing your time and knowledge with us. And also thanks to everyone who has joined us today. We hope you actually benefited from the session. On behalf of MSAUN KNH Academics Department, we wish you all a productive evening ahead. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. السلام عليكم ورحمة الله وبركاته.
Ini aja nafanya mtu.